Welcome. I'm super excited to be here today. I have Dr. James Kustow with me today, and James is one of the UK's leading experts in adult ADHD and complex neuropsychiatry. He is a consultant psychiatrist and medical director of the Grove practice and director of education for UCAN, which is the UK Adult ADHD Network. Now, his work sits uniquely at the intersection of ADHD, anxiety, hypermobility, EDS, dysautonomia, and emotional regulation. James is the author of a new book, which is amazing because I have read it and listened to the podcast, on how to thrive with adult ADHD, which reframes ADHD not as a deficit, but as a different neurotype, offering practical tools for adults to improve clarity, emotional balance, and functional performance. So that's a bit of a mouthful, James, but welcome. And can you tell us a little bit about yourself?
Wow. Okay. A little bit about myself. Well, I'm a medical doctor who chose at the very last minute, even after I'd finished medical school and the first few years of working on hospital wards in a sort of medical and surgical environment, I had a sort of, I suppose, a sudden moment of clarity, and I realized that psychiatry was probably my calling.
Okay.
And I hadn't even considered it prior to that. And I journeyed through the training of becoming an adult psychiatrist and specialized, particularly at that stage, in something called liaison psychiatry, which is exploring the interface between body and mind, physical and mental health. So right from the beginning, I was a psychiatrist interested in the body.
Yeah, you've almost dovetailed that, the mind-body connection very, very early, which is awesome, which hopefully we're going to touch on a lot more today. So maybe just as a framing to sort of start things, can you explain a little bit about ADHD in terms of, there's been a lot more discussion about it in social media, out in the media, more diagnosis at the moment. But how do you define this relatively simply?
Yeah. So how do I define it, or how is it defined?
Well, I suppose maybe there's two different.
I think it's understood to be a neurodevelopmental condition.
Yep.
Which implies, it means that it affects the brain and it takes root during early development.
Yep.
And it's one of a number of different neurodevelopmental conditions, including autism and dyspraxia and dyslexia and Tourette's and etc.
And is that all a spectrum?
It's not one spectrum, but I would probably describe it more as a network of overlapping and intersecting neurotypes, as you used the word before.
Yep.
There's quite a lot of overlap, but they are distinct.
Okay.
And they're, as a group, very genetic in origin.
Okay.
So it's interesting because many people question the validity of ADHD as a real thing.
Yep.
And it's one of the most genetic mental health stroke neurodevelopmental problems out there. It has a heritability, which is a percentage figure that indicates how genetic something is versus how environmental it is. And the heritability of ADHD is 70 to 80%.
Which is high because there's not many other genetic types that are quite so high.
Well, if you look at depression and anxiety, their genetic imprint is much, much lower.
Yeah.
ADHD is a very biological thing. It's a very physiological thing.
But the environment can definitely impact that.
Absolutely, without a doubt.
Yeah.
So as is the case, so the genetics are not, that you will, it's not so clear cut that if one parent has it, you've got a X percentage chance. There is quite a high chance of it passing through generations, but it's a vulnerability, and then environmental factors may express it more. And we know that. We know
activate
as the environment.
Or deactivate.
Yeah. And the environment's very relevant in ADHD.
Yep.
And the name ADHD, it's a bit of a misnomer, to be honest with you. It stands for Attention Deficit Hyperactivity Disorder. And I take issue with much all of those words because, first of all, central core symptoms include attentional dysregulation and certainly in kids, hyperactivity in some.
Yeah.
But it's not always attention deficit, and there are many more aspects or domains that become dysregulated in ADHD. So with my book, I introduced a new way of conceptualizing ADHD that has really sort of inspired lots of people, because I think many people find it really difficult to define or describe ADHD.
Yeah.
Get caught up thinking about attention and then getting confused by the fact that many people with ADHD can sit and hyperfocus for hours on end.
Yeah.
And it's very far from the attention deficit that's in the name. So I understand ADHD to be an issue with, or a disorder of, regulation.
Yeah. So emotional regulation.
Well, and I have a model called the 10 domains of dysregulation.
Yep.
And the first 4, I call the core 4, are what we would commonly recognize to be ADHD. So the first one is attention and executive function, so dysregulation of that domain.
Yep.
The second is activity, and it's the sort of hyperactivity, but also at the opposite end of the spectrum, the sort of reduced activity, the apathy, the lack of motivation, the stuckness.
Yep.
The third one is impulse control, and the fourth one is emotion. So emotional dysregulation is widely considered to be a core symptom or feature of ADHD, although it's not in the diagnostic criteria at all. It's an associated symptom, but it very much is. But then there are 6 others, and that's where it gets more interesting.
Interesting. So we talk about it as a bit of a spectrum. Is that why it can present so differently in different people?
So it does. That term you described is referred to as heterogeneity.
Yep.
So it's
and being a spectrum.
Yeah, variable presentation. The spectrum. So most people will think of the spectrum when thinking about autism, but it's important. It's worth mentioning the idea. ADHD is not a categorical diagnosis. It's not you're either in or you're out. You're diagnosed as in or out according to a cutoff point.
Yep.
And the cutoff point is the point at which the characteristic cluster of symptoms, which we touched on just before, reaches a threshold of impairment, like functional problems in one's life.
Yep.
And it's a judgment call.
Yeah. Yeah.
And that's why the assessment needs to be really rigorous and thorough.
Yep.
Because the more data you have, the more able the assessor is more able to make a good judgment call to see, is it causing problems in life? So, yes, it is on a spectrum, a bit like blood pressure. Everybody has pressure in their system, and at some point along the way, it's harmful. And that's referred to as hypertension, as you know. Now, this concept of heterogeneity, of difference, I actually refer to it in my book as one's ADHD signature.
Okay.
And I think that I've developed a framework for mapping out the ADHD signature. And just in a nutshell, it includes this called the ADHD signature quadrant framework. And the 4 parts of the quadrant are the mapping of the 10 domains of dysregulation, then a look at comorbidity, and comorbidity is co-occurring problems that journey along with ADHD at higher rates than you'd expect. And that falls into 4 categories. One is mental health comorbidity, then there's neurodevelopmental comorbidity, somatic or physical health comorbidity, which I know we're going to talk about, and then addiction-related comorbidity, because there's a lot of overlap between ADHD and addiction-related issues. And the 2 other squares are interesting. They refer to the negative outcomes that have already occurred or are threatened in that particular individual. Have they lost their job? Is their relationship struggling? Are there other sort of really negative outcomes that are impacting their life? And the other
Is that sort of all related to their past experiences?
past, but also present, what's going on now?
Yeah.
And then the other square of the quadrant is the adaptive or positive attributes linked to the ADHD. Because having a different brain, a brain that's a bit less inhibited, can be potentially incredibly powerful.
Yeah.
If you're able to tame it, manage it, work with it. Mm-hmm. That's the premise for the whole book, really. Now, those 4 quadrants make up the sort of core of this ADHD signature. And right at the heart of that is mindset, which we can talk about in a bit. And around it are 4 scaffolds. Scaffold, family and partner. Scaffold for social and maybe occupational. Scaffold for spiritual, and a scaffold for therapeutics. So your psychiatrist, your GP, your therapist, and other practitioners, body-based practitioners supporting you. So there's a model there that tries to capture the complexity of ADHD. And yes, although there are similarities from person to person, there is distinct difference, and mapping that out is important.
Which is why you can have such variability in how it presents in different individuals.
You are, with the common thread being dysregulation in many areas.
So coming on to ADHD, and you discuss it in your book quite a lot. ADHD we often see that in high achieving individuals because they have the ability to be able to hyper-focus or excel or go very deep in a certain area and in a certain field. And these are often individuals who've learnt different coping strategies along the way. Is this something that, a lot of people are able to sort of fly under the radar with for a long period until they reach perhaps a negative event that brings it to the fore?
So under the radar, if you're trying to mask and keep it from people, maybe. But the truth is, in most people, these are traits that are setting in childhood and building on. Now, the difference, there are reasons why some individuals will go down the heavy impairment track and others will find a way through. And if you're asking what the factors are that influence how someone can thrive with ADHD, it's the title of my book, then I think it's about recognizing one's areas of struggle and not hiding from them, but working with them. Also recognizing your areas of strength and pretty much setting your life up around those areas. And fundamentally, I always tell people, the mistake we often make is we spend our life trying to overcome the things that we're just fundamentally not good at. Mm-hmm. And I think it's about learning what those things are and setting your life up so you have to do them less. And crucially...
Or find ways to build or scaffold around them if you can't not do them.
Exactly. Find ways to manage them otherwise. But fundamentally, if we're talking about someone being successful in a team environment, in a company environment, it's absolutely about bringing in people who will complement your skill set, will not judge you, will accept you, understand you, and that there's an open acceptance within the team unit of what you're really good at and what you struggle with, and that other people can balance things out.
So they can work to your strengths.
And I actually think that is the model for every team. And the success of every team. Because at the moment, people are walking around with huge amounts of shame, hiding their deficits, and actually end up spending 80% of their time trying to do the majority, 80% of their time doing the 20% of the stuff that they are rubbish at,
not good at,
the admin stuff, and trying to cover it up and compensating by staying late and not telling anyone. Imagine a world where you could come in and say, actually, if you get someone else to do this bit, you'll get a much better AI,
for example.
Exactly. Yeah, I'm a big fan of AI.
Yeah.
When used appropriately. And
I mean, it's a massive efficiency driver. You know, we're building an AI health intelligence platform at the moment, and the amount of detail and work we can assimilate very, very quickly using a lot of the tools out there that would bore me.
No, it's a game changer.
Is just remarkable.
Yeah, it's going to change the way that we work fundamentally.
Completely.
And I think it's a very good thing for people with ADHD.
Yeah.
And I think we need to be embracing it and learning how to use it effectively. I don't see it as cheating. I see it as, you know, it's just a different way of collating and integrating information.
Yeah, completely. So what are some of the key little traits that you've identified in people that can lead them with ADHD to be successful, or that, you know, hyper successful individuals?
So I would say the top of the list is mindset.
Yep.
And you may have seen the work of Carol Dweck, who talks about growth mindset versus fixed mindset. So nurturing a growth-oriented mindset. You know, you have to accept, if you have ADHD, that you're going to have setback after setback.
Yeah.
And you will have had throughout your life. If you have a mindset that says, I'm going to pick myself up, dust myself off, and stand tall and basically move on and learn from the experience.
Yeah.
Because by being impulsive and excited and diving in perhaps before we've got all the information, that risk-taking is both a problem, but it's also a way to break through.
Yeah.
And much learning comes from taking calculated risks and then realizing what went wrong when it goes wrong, and diverting, and then I think we learn quicker that way. So the real problem comes when you, when every time that you fall, you see it as a
real
personal
negative
deficit, and that you're rubbish, and that, you know, all this narrative, internal and actually expressed self-deprecating narrative is highly toxic. Yeah. And so I think having a growth-oriented mindset, which is all about learning and growing and not judging negatively and asking for help when necessary and picking yourself up, I would say that's fundamental. And the second thing is really thinking about what I call the basic housekeeping, getting stability in your life through good nutrition, good sleep, and lots of movement. Yeah. And having structure and anchors throughout your day that help keep you grounded. Yes. And once that foundational stuff is in place, you know, there are going to be things that come along and rock the boat. Yeah. But when that foundation's there, it's much more likely that the brilliant stuff can shine through.
Yep. Interesting. So, James, there's a lot of discussion, and we identify it clinically in a lot of our patients, that there's this overlap of different symptoms and ADHD, anxiety, often different sensory disturbances, you know, dysautonomia, hypermobility as well as a spectrum, and maybe EDS, which is Ehlers-Danlos syndrome. I know you've touched on with your core pillars, but is that why that we see these overlapping sort of symptoms or traits?
Well, I think it goes back to this question of, you know, what is ADHD and how broad is it? Yeah. So the 6 other domains actually are, many of them you've touched on. So within the emotion one, which is number 4, I would put anxiety firmly there. And anxiety, I don't think I know a single person with ADHD who doesn't experience some form of anxiety. Yeah. It's not in the criteria. It's not even mentioned. The reason that's the case is that the criteria are there not to best describe ADHD, but really to help differentiate it from other things. Yep. And we get confused by that. We think, what is ADHD? We'll look at the criteria. And there's not a mention of anxiety. And there's not a mention of a whole load of other things as well. Certainly not body-based things, because by definition, ADHD is a neurodevelopmental. It's all neck and above, but it's not all neck and above.
No.
It's a very body thing. So just to give you a flavor of some of the other domains, there's reward system dysregulation. There's time appraisal dysregulation. Sleep or circadian rhythm dysregulation. But there's also, in many people with ADHD, not everybody, but in many people, immune system dysregulation. Higher rates of inflammation, allergy, autoimmunity, etc. Atopy, which is like asthma and eczema. Not well explained presently. And there is dysregulation of the autonomic nervous system, of the system that, well, it does a lot of things really, but it essentially manages all the autonomic functions, automatic functions.
So we're talking about your parasympathetic and your sympathetic nervous system here.
Yes. So this autonomic nervous system is a balancing act between two opposing forces. The sympathetic, which is the stress response, it's when it prepares you for fight or flight. And then the parasympathetic nervous system, which is a balancer, the rest, digest, regeneration, repair mode. It's when the system says, I'm not in danger, and I can go back to the basic housekeeping of the gut function and so on. Now, when that's imbalanced, that system, it's called dysautonomia. And essentially dysautonomia is a cluster of different presentations. The best known of them is POTS, or postural orthostatic tachycardia syndrome. The whole area is fascinating and certainly really currently quite neglected by the system, by the health system. I think because we're not particularly good at looking multi-system problems.
We're not at all.
We have become much more
very
specialized. I remember even when I went to medical school and I was training to be a doctor, there was this transition from people being general surgeons and then narrowing down to like colon surgeons, and then the sort of sigmoid colon surgeons, and then narrower and narrower. And I think although that does make sense when you're talking about surgery, because you want to become a real expert on your particular area, we mustn't lose the big picture.
As a physician, I almost tell our team that, I want you guys to be specialist generalists. Like, we need to be broad in our specialism across a whole host of areas because we see multiple things. We're not, surgeons. You do want a surgeon to come in and go, right, I'm very, very good at nailing that first toe for a hallux valgus or, a bunion surgery. But everything else, okay, fine, we can pass on to someone else. But I think in situations,
it doesn't quite work. And the biggest silo, as you call it, is mental health or brain health. I think we're actually at this time going through a bit of a revolution without people realizing it. I think there's a transition from mind problems to brain problems. As we understand how the brain works better, we're going to realize that brain and body is everything, really.
Completely.
And mind is a manifestation, and when it affects behavior, it gets called mental health. Whereas actually, I'm much more in favor of thinking about brain health. So
it's a kinder term. Mental health probably doesn't always come with nice connotations all the time.
True. It's true. I think that for a very long time, and we could debate the reasons for it, there's been this artificial divide between mental and physical. And it's starting to really cause a disservice. Even the specialities, medical specialities and psychiatric, they're very, very disparate. They're separate. And they sort of leave all the other stuff to the other. But actually, that's got to stop.
I mean, the whole system works together. It functions synchronously.
But and the health system should as well. But it doesn't.
That's a whole nother.
And I think it's starting to crumble. And I think the problems that affect multiple systems of the body that have a very clear physical imprint, but also a mental health, neurodevelopmental imprint, those are the ones, like Ehlers-Danlos syndrome, those are the ones that are the forefront of this clash.
Yeah.
And I think most people with EDS or hypermobility and related problems will say that this just that no one gets it.
Completely. And I think it's a bit of a, to these clients that you start diving into, ask some of these questions. They might come in and you run a Baton scale on them, and the Baton scale is a hypermobility scale for everyone, which tests a number of different joints.
Yeah.
And a lot of the time you might then dive into some gut health or some sleeping, or, do you react with injections in a different way, or so they start, you start asking some of these questions, and then like, oh, okay, am I joining the dots up a little bit here? To understand that they've sometimes got these funky immune systems. Their pain systems can be pretty hyper responsive at times. They might have multiple injuries as well, and they've had gut issues and this atypia or atopia, and some mast cell activation stuff going on. And so this collection of symptoms often starts making a little bit more sense if you bring it under some of these umbrellas.
Sure. So the first differentiation is between hypermobility that's not causing any problems. So someone who's a bit bendy can, is a good gymnast or a ballerina or, whatever, is using their hypermobility and it's not causing them any problems.
And there's a lot of athletes out there like that.
Loads. And it actually does give an advantage if you don't get injured.
Yeah.
And then separating that from hypermobility syndromes. And the two clusters are, as you well know, Ehlers-Danlos syndrome.
Yeah.
And there's 13 different types of Ehlers-Danlos syndrome. But without doubt, the most common one is hypermobile Ehlers-Danlos syndrome.
Heads.
And then a sort of catch-all category called hypermobility spectrum disorder, which is hypermobility plus pathology, but not meeting the threshold for Ehlers-Danlos syndrome. But I can tell you, I have HSD. It's again very heterogeneous. It's got many different expressions, but it can be quite a serious thing.
Yeah,
and
completely.
people are suffering a lot within that group.
Yeah.
And this is where the additional pathology comes in. Now, that might be the obvious one to think is if, because we've become stuck on the idea that hypermobility is just affecting joints.
Yeah.
But it's not just affecting joints. It's affecting connective tissue, which is system-wide. We think of it as tendons and ligaments affecting joints. But joints are certainly important, and especially for your crowd.
Yeah.
And, the pain through injury or dislocation or subluxation or, the dynamics that are altered are certainly a big category. But the connective tissue wraps around blood vessels, and it is important around wrapping around the guts and helping that movement, that peristaltic movement through the gut. It's got functions throughout the body, the eyes and eye movements. And what you see is when the connective tissue is lax, so its collagen and elastin are more lax, it just has very characteristic effects in every system of the body.
Yeah.
And separate from the direct effects from that lax connective tissue is the knock-on effect that the immune system has in response to that.
Yeah, completely. I almost liken, and I explain this to some of my hypermobile patients or someone who lacks stability generally as well in certain areas. And I often sort of explain to them, well, look, if you've been walking around for a lot of years on an unstable body and your computer has needed to sort of be on alert to avoid twisting your ankle or dodging that pothole because you go over on your ankle, and the system's working so hard all the time, that's going to wind up your central nervous system. That's going to wind up everything. You're always in that state of high alert. So you're almost sympathetically driven. Is that contributing to everything that we're seeing with these
100%.
individuals?
100%. I refer to it as, rather than connective tissue abnormality, I refer to it as like fascial dysregulation. If your fascia or connective tissue is lax, and you're going to be having micro injuries very regularly. And this is where the mast cells get involved. So I think, so let me answer your question first, and then we can segue into mast cells afterwards.
There's a lot we could segue into.
There is a lot. I feel like there have been many questions you've asked, and we've only got part way through, and I haven't done the second part of the earlier question, but anyway. So if you're getting micro injuries, and also the proprioception, the awareness of where your body is in physical space, which is a complex sensory, so it's one of the 8 senses. And if your proprioception is slightly off, which is the case when your connective tissue is dysregulated.
Yes. Because I'll just touch on there, because our receptors feed that information in, and the receptors are not working as effectively in someone who has that elasticity.
A particular type of receptor, mechanoreceptors, sensing movement, and the movement is slightly different. And so when the proprioceptive function's slightly off, it sends a message to the brain that this isn't quite safe. And there's the secondary effects of many previous situations where you've got stuck in that pothole.
That's exactly what happens with pain as well, and sensory input as well. Like, it's very, very similar pathways, or the same pathways, really.
See, I think we see, you don't because you understand this area well, but many people see the connective tissue as a musculoskeletal thing, but actually it's a sensory and a signaling organ almost. It is capturing huge amounts of information all over the body, and the way the organs are functioning and moving, and musculoskeletal stuff. And
it's the biggest glucose regulator as well.
And hormones as well. It's estrogen and relaxin receptors throughout it, particularly in skeletal muscle. And it's sensing through proprioceptive functions and signaling to the brain about safety. And we know that if we're not safe, if the things are not quite right, then we'll be in that sympathetic dominant state. And it's really important to recognize that when there's an imbalance in the autonomic nervous system and the sympathetic drive is high and the parasympathetic drive is low, that has an impact on immune function. Because the parasympathetic system is pretty much made up of one nerve, the vagus nerve. And the vagus nerve has a direct link to the immune system. And so when you are not getting good parasympathetic tone, your immune system's compromised. And your sense of safety is compromised. And ability to relax. And it's really interesting, many people with hypermobility related issues, and interestingly ADHD, there's great overlaps. There's almost half individuals with ADHD from the research we have are hypermobile.
So I was going to touch on that.
Fascinating.
So half of ADHD individuals diagnosed ADHD are hypermobile.
The study was by Jessica Eccles and team, but the study actually showed that about 50% of the group of individuals with neurodevelopmental conditions, of which 62% had ADHD, were hypermobile, and slightly less were just from the ADHD group. But this is one study, and we're looking at somewhere around the 40-50% mark, which is certainly double the normal population rate, if not more.
Which is a massive number of people, particularly when we see a lot of hypermobile individuals in our clinic.
Absolutely.
And we're now sort of identifying different traits within them that might help us to understand why they've failed rehab elsewhere, why they have difficulty in other aspects of their life and committing to regular exercise?
Yeah, it's a real challenge.
Which actually is one of the best things that you can possibly do, in my view, to help to stabilize the whole system, not just the musculoskeletal system, but the brain. Would you agree with that?
Yeah, look, just to give you a personal anecdote. So I'm open about this in my book. I was never open about this previously, but I have ADHD, which was diagnosed in adulthood at the age of 34 years old. And I honestly, I've had, with the hypermobility stuff, I've had so many injuries, particularly when I played rugby. I would get injury after injury.
Yeah.
And I've seen
a good sport
many
for that as well.
physiotherapists. The injuries are because my joints were more vulnerable and I was a bit more impulsive and got a bit overexcited, and I was good at rugby, but I got injured. And I've seen many physios over the years.
Yeah.
And I always struggled to do exercises at home and I never understood why. And I always sort of, I'm rubbish, I'm this. You sort of internalize these things. Nowadays, when I get an injury and I go and see a physio, I'm very clear, I'm very open that I don't work very well with exercises at home. So anything that we do needs to be integrated in my day-to-day function.
Yep.
If I'm walking up the stairs or walking down the stairs, what should I emphasize?
Little squats,
little changes. And if I'm sitting at my desk, what can I do then? Just really functional interventions. And if you think about that, but in every other speciality that you might see in terms of medicine and doctors, if you're aware of these things, you can adapt the interventions to work better with it.
Completely.
But there's no doubt that the majority of people who you're seeing well, not the majority, probably the majority, but there'll be a much higher than expected proportion of people with neurodevelopmental problems and mental health problems to not think about this as part of the treatment is missing a trick.
It's missing a big trick, because you can't optimize your treatment for that particular individual, because otherwise you're giving a very generic treatment that they're probably not going to adapt with because of certain factors.
Yeah.
What will hypermobility drive anxiety?
Yeah, for the same reasons we talked about. The system doesn't feel safe.
Yep.
You're on guard, you're hypervigilant, your body's hypervigilant, your immune system's hypervigilant. And what is anxiety? I mean, anxiety is too much sympathetic tone and laden with fear about negative consequences and a sense of not being safe. Many people can't. There's anxiety which is linked to something specific. I'm anxious about the exam, or I'm anxious about going to meet some friends in the pub or something. But then there's free-floating anxiety with no obvious cause, and sometimes that's like more of a physical anxiety, and probably more of an autonomic nervous system dysregulation, or an inflammatory anxiety. So more of a mast cell, and it's not just mast cells, but more of the immune system that's releasing too many chemicals, and those chemicals, make you feel different, anxious.
Maybe this is a bit of a tangent, but while you've just brought it up, does the anxiety present in different ways depending on what might, if it was more of an inflammatory sort of immune response as opposed to that physical response? Is there a difference that you can determine and what might be driving it?
Yeah. So first of all, just in terms of thinking about anxiety, there are many different presentations of anxiety. So there's generalized anxiety, social anxiety. There's anxiety in the context of obsessive compulsive disorder, anxiety in the context of trauma, PTSD and beyond. Trauma is much more than just PTSD. There's phobic anxiety, being sort of fearful of particular things. And so obviously you might get some direction in terms of that sort of anxiety. It's the anxiety when there's no particular focus, and that it's associated with a feeling of being unsafe, of being on guard, and I think irritability is quite an inflammatory symptom. And I think when there's a rise in anxiety, it's really important to look at the context. What have I just eaten? What have I breathed in? Just in terms of the trauma links with anxiety, if there's a trauma in place, what I mean by that is that there's an event that's taken place or multiple events that have taken place that haven't been fully integrated. And when something's fully integrated...
When you mean integrated, do you mean processed?
Processed.
Appropriately?
Processed. So when you experience something traumatic, it's in the hours and days afterwards, there will be an organizing of that. It creates a charge. A charge means that you're full of emotion and your physiology is in this heightened sympathetic state. Now, that doesn't last forever with most people. Normally, all the learnings and the experience and the memory is taken away and filed. The emotional components are digested, as it were, and the person moves on with their life. I think dreaming is an important part of that process. However, for various reasons in some individuals, and there's discussion as to who's at more risk of this, that integration, digestion, processing doesn't take place. Often it's when the event was too overwhelming, or the individual hasn't reached a place where they're safe yet. But that processing doesn't take place. So that memory is almost tied together with the emotion and the physiology. Every time there's a reminder of the memory, a smell, a word passing through an area, that whole physiology and emotion is activated. And that goes on indefinitely until that's processed. And what tends to happen is that people don't like that. So they avoid anything reminiscent, and their life becomes narrower and narrower. And, the one extreme of that is post-traumatic stress disorder. Now, that sort of anxiety is absolutely, that's a big category. And many, many forms of anxiety are linked to trauma. And often you don't know it because the individual doesn't really want to talk about it because they're trying to avoid it. So it's when you see a body reaction in response to a word, a sound, a smell, you think trauma. But when there's no clues as to where it's coming from, and the individual has this cluster, you should be thinking about dysautonomia and inflammation and connective tissue dysfunction as well. They're all very much intertwined.
When you're thinking about dysautonomia, are you starting with the gut as a starting point? Are you starting to think about some other sort of environmental factors in terms of, mold and pollution and the air that we're breathing, the water that we're drinking?
Dysautonomia, I think some of the stuff that you mentioned is more relevant to the immune hyperreactivity rather than the dysautonomia, although those two are very, very connected. In terms of dysautonomia, as well as being the stress, one of the main stress systems of the body, the autonomic nervous system is responsible for basically perfusing, sending blood to organs in the body. And the reason why it's the stress system of the body is because depending on the situation, you want to prioritize certain parts of the body. So, if you're fighting or running, you don't really want to prioritize the frontal part of the brain where you start to think and debate and stuff. You want to just get out of there. You don't want to think about the gut. It's a
survival mechanism, really, isn't it?
You don't want to think about the gut because you don't need the gut then. You want to channel the blood and oxygen to where it needs to go. Dysautonomia basically means an inefficient movement of blood around the body. And one of the areas that suffers most or most obviously. The gut suffers a lot,
Yeah.
but is the brain. And a big clue to dysautonomia is the presence of orthostatic symptoms, symptoms that occur on standing. So a typical story of someone with dysautonomia is that they get symptoms. Usually it's dizziness, lightheadedness. Sometimes, particularly in POTS, it's a rapid heart rate, like palpitations on standing, which is worse when it's hot or worse they come out of the bath. And it causes this dramatic, acute orthostatic intolerance. Now, that's quite a dramatic, obvious presentation. But when it's more subtle, more chronic, and there's just generally not enough blood getting to the brain, the picture's less obvious. People might report brain fog, or they might report anxiety, or I need to lie down, or fatigue. You don't automatically think about the autonomic nervous system. You think about why they've got fatigue or they've got anxiety, and we don't think in that term. So the brain symptoms of dysautonomia, the brain fog, the anxiety, the fatigue, and a lot more but that. Then there's the gut symptoms of dysautonomia. If there's not enough blood going to the gut, it's not working properly, the gut becomes sluggish. It slows down. Reduced gastric motility. So there's gastrointestinal motility, less movement through the gut. And then you get this spiraling effect. If there's not enough movement through the gut, in fact, any tube that's got fluid in it, that's not moving, like a river, gets blocked. What will happen? The water will stagnate, and you'll get growth of things that you don't want to be there. And imagine that's going on in the gut. The toxicity that results from
the
that.
Bacterial growth.
Bacterial and fungal, and it's called dysbiosis. It causes damage to the linings, the absorptive functions. It changes everything in the gut. And things don't get broken down in the same way they should. Toxicity, the lining of the gut becomes damaged. It's called intestinal hyperpermeability. And things get into the bloodstream because the gut's a direct link into the bloodstream. Things get into the bloodstream that shouldn't be there. And toxicity and inflammatory stuff gets in, and it goes to the rest of the body. And so you get this characteristic when the gut's not working well, which might be because of dysautonomia and impaired peristaltic movement, as we've talked about. But it also might be because the mast cells, which are lining all the environmental interfaces of the body. So we should talk about mast cells properly, but they're lining the gut. And if they are sensing that there's danger around, i.e. toxicity, which we've just explained why, they're going to be releasing inflammatory chemicals,
so
which
histamine.
swell the gut. So you've got this combination of poor motility through the gut and swollen linings, which really limits flow further. And then you get a cascade of inflammation and toxicity, which most certainly goes to the brain. People think that the blood-brain barrier protects the brain from all bad things. This is not the case. The blood-brain barrier gets damaged, and things get through that shouldn't get through, particularly in the sort of later natural history of these problems. It's complicated.
So we've dived pretty deep there, and we could keep going further, but I might just pull it back a fraction, if that's okay.
Sure.
So in terms of hypermobility and anxiety, or patients that we see a lot of the time who have these musculoskeletal disorders, but present with these other, not really comorbidities, but other characteristics, what are some of the most important things that they can be doing from a physical and brain health point of view to help to optimize themselves?
Well, work out if they've got ADHD.
Yep.
First of all. And
do they need a diagnosis for that? I mean, you talk in your book about us working out whether you want a diagnosis and going down that pathway, because it is pretty extensive, isn't it?
Yeah, look, it's heavily under-resourced presently in the NHS. and it has been for a while. And that's really problematic because ADHD is really common. And in relation to the early question, which is we've seen a significant increase in number of people being diagnosed and going for assessment. And it's a big question, isn't it? What's the reason for that?
Can I stop you there for a second?
Sure.
Can you throw out what percentage of population that we think might have or sit on that ADHD spectrum?
Sure. So in adults, it's somewhere between 2.5 and 4%.
Okay.
Based on the studies.
Yep.
Now, according to the population numbers, the number of people, adults in the UK, that would equate to 2.5 million adults being diagnosed with ADHD.
Yeah.
Presently, we have to estimate this because there's not good data, but based on prescribing data, the rationale being that if someone has a diagnosis of ADHD, a lot of them will be
medicated
on medication. So prescribing data would suggest that somewhere between 300,000 and 500,000 people are actually diagnosed. It might have changed over the last couple of years because of this big upsurge. That's a lot less than 2.5 million. So anyone who says that ADHD is overdiagnosed presently is just wrong.
Yeah.
You have to remember that this is a condition, a cluster, whatever you want to call it, a thing that's not new. It's been around since Paleolithic times, and we know that from genetic studies. The genes that constitute ADHD have been around in the gene pool since Paleolithic times, and actually there's evidence to show that the genetic cluster is actually reducing over time.
Interesting.
Now, I don't think that, remember we talked about the combination of the genes and the environment?
Yep.
There are huge environmental changes going on in our world right now. And if we're saying that ADHD is overlapping with immune dysregulation and our immune systems are the systems that's registering the environment.
Yeah.
Because what is the immune system there for? It's there to detect a threat and to mount a response to keep us safe.
Yep.
So, and the mast cells are fundamental in this story because the mast cells are the first line of defense.
Yeah.
They're the first responders. And that's why...
And they're inflammation cells. If we're
so
just touching
they're
on...
white blood cells that don't live in the blood. They might travel briefly through the blood. They're made in the bone marrow and they journey to their destination. And where is their destination? It's at every part of the body that meets the environment. So the skin, eyes, ears, nose, throat, gastrointestinal tract, genitourinary tract, and respiratory tract.
Yep.
And they're particularly concentrated at that environmental interface. They have receptors. They're amazing cells. They're brilliant. They're like... You've
drawn some pictures of mast cells.
I've done some paintings, pictures of mast cells. Well, one. But they are amazing cells. They have receptors on their surface that register infection, allergen, toxin, vibration, heat, cold, hormonal changes. They've got receptors on their surface for estrogen, for stress hormone, the CRH, which is corticotrophin releasing hormone. Basically, they detect anything. And when they detect a problem, they release a concoction of different chemicals. There's hundreds of them, but the best known one is histamine. Histamine is released and it causes redness and swelling on the skin.
Erythema that we see.
Exactly. And the reason that you release histamine is because it widens blood vessels and blood is released into tissues, swelling takes place, which immobilizes joints. The increased blood supply brings in other blood cells, white blood cells that are there to attack the infection, if it's an infection, clean up afterwards. So all of these different chemicals have different functions. Some of the chemicals they release widen blood vessels, like they're vasoactive. Some create pain. Pain's good because it immobilizes things. There will be various different functions.
A vast array of things.
And some of the chemicals are preformed and others are formed quickly in response. But in some individuals, for a variety of different reasons, sometimes genetic and sometimes environmental, the mast cells are jumpy. They respond too quickly, too early, too much, releasing too much inflammation.
And is this what people are terming mast cell activation syndrome?
Exactly.
And it's a little controversial, that area, because, you know, the blood test markers to technically or be diagnosed with that are extremely high. So you're almost talking at sort of an anaphylactic shock type level.
So it's not, so that's, there's two overlapping themes there. So there's two camps around. So mast cell abnormalities, mast cell activation abnormalities have historically just been limited to something called mastocytosis, which is a very rare and very serious condition. It's a bit like having cancer of the mast cells. Mast cells proliferate and produce more chemicals and so on. It's very serious and very rare. We're not talking about that here. We're talking about a much larger group of people who don't have mast cells that are proliferating too much, but that have mast cells that are releasing too many chemicals and too easily. The threshold is reduced. And there's lots of debates as to why that's happening. But something, usually it's environmental, something, usually at a low level for a long time, is activating the immune system. It might be an infection that has a latent infection.
So UTIs.
It could be. It could be infections like gut-related infections. It could be herpes-type infections. It could be fungal infections in the gut or other places. It could be Lyme disease that's never been properly treated. It could be that that individual's living in a moldy room and the mold at a low level is activating the mast cells continually. It could be that the individual is continually having micro injuries of their joints through hypermobility. Or it could be that the stress that someone's under because they've got unresolved traumas is meaning that more CRH, the stress hormone, is locking into the mast cells and dysregulating their function. Basically the innate immune system, so the immune system made up of these cells, including the mast cells, is on high alert. It's basically overactive, and after a while, it remains overactive, and often this is preceded by some big insult of some form. The story of someone having a significant mold exposure and never recovering, of Lyme disease.
Lyme disease is a big
of
factor.
Glandular fever, of a car accident. COVID. What happens is these vulnerable individuals who up until that point have had a patchy, inflammatory thing, a bit of hypermobility, a few injuries, nothing too significant. Maybe recurrent infections in childhood, like tonsillitis every few months or couple of months. Something happens and their mast cells go from being a bit edgy to being like ramped right up. And they stay in that state. Now, what state do I mean? I mean tired,
heightened,
wired, brain foggy, in pain.
Fatigued.
So fatigue, pain, brain fog, and importantly, heightened sensitivity to the environment. The altered sensory set point, as it were. Why is the sensory system at this level? Think about it. The body is in this hypervigilant, we're in trouble, we're under attack. We need to be on the lookout. Of course, you want to set your sensory system so that it picks up the earliest signs of the problem. And the issue is that the system, the immune system and the neurological system, because mast cells there's a sort of integrated relationship between mast cells, connective tissue, the fascia, nerves, and blood vessels.
Yeah.
Mast cells center around nerves and blood vessels.
And is this part of, we're not designed for these chronic, persistent, low-level stresses. Our whole system is built to run away from the lion, to, hibernate when we've had trauma or an injury or an infection and heal ourselves. Yet in our current environment and modern world, we just crack on.
Yep, that's true. But we are also being exposed to an unbelievable amount of toxicity, chemical toxicity, electromagnetic toxicity. I know it's a controversial area, but we are being bombarded by chemicals. Since the Industrial Revolution, there's well over 100,000 newly generated chemicals that are in our environment, in the water we drink, in the food that we eat. And we are living in a different way. The way that we live in our homes is very, very different. So many subtle things. Like, you will have noticed that people are insulating their homes, sticking insulation on the outside, which is a good thing. You're keeping in heat and so on. But you're also stopping the home breathing. Yeah. And we are making all these subtle changes to the way we lead our lives. And they are undoubtedly going to be having small additive effects on our immune system. Yeah. And it seems very logical that the more sensitive individuals, the individuals that are more likely to be in this group, that is individuals with hypermobility. Yeah. And it depends which way around you look at it. And mental health, neurodevelopmental problems, dysautonomia, and gastrointestinal problems, this is the group, are going to be the first people who are affected. They are referred to as the canaries in the mine. Yeah. So they are going to get ill first. Yeah. Yeah. Our immune systems are able to tolerate a lot, but there will be a point where that threshold of being able to tolerate stuff is reached. Yeah. And then there's decompensation. Yeah. What does decompensation look like? It looks like all of the things we're talking about. Yeah. And there's a model that I've developed which tries to capture this. Yeah. Built on previous work. It's called the neurosomatic super syndrome. And it's basically the cluster of mast cell activation disease, hypermobility syndromes, dysautonomia, gastrointestinal motility dysfunction, and autoimmunity, which is another aspect of this group. And all of these things are driving neuropsychiatric symptoms, neurological and psychiatric. And that is, just to list them, because it's really important, people don't realize that. So there's the dysregulated stress response and anxiety. There's the mood and sleep disturbance. There's the dyspraxia coordination stuff. There's the brain fog ADHD stuff. But there's also the more neurological stuff. There's the pain and pain syndromes, sensitivity and sensory processing stuff, and fatigue syndromes, and a few other bits and bobs. But all of that cluster is strongly associated from that. And any brain effects are likely to be secondary to systemic effects. Yes, yeah, completely. So we need to stop just looking at the brain and start looking at the whole system. Yeah. This is a big group of people, and COVID has unmasked them.
And that's, this has been utterly fascinating chatting, James, and I'm going to sort of try to wrap it up a little bit here, because we've dived in so many multiple areas, and I've loved it.
You don't talk very much about ADHD though, which is maybe that's another talk.
But yeah, we're trying to sort of wrap it back together. But you're a fount of knowledge across ADHD, how to manage hypermobility, mast cell activation, the emotional dysregulation across multiple systems. But if we had to bring it back a little bit, because we see a lot of these patients end up in our clinics. And they're have this collection of different symptoms,
Yeah.
and we're having to treat them very, very holistically.
Yeah.
And look at them and educate that these patterns are all interlinked, and we need to look at every sort of system together, which is looking at their sleep, their stress, their diet, their mental well-being, their exercise function, and their immune system, this whole sort of pattern. And I've missed out multiple areas. But how do we bring it all together?
Okay.
What are a few simple, easy tips, maybe not easy, that we can try to think about with these type of clients?
Sure. So this is a question I asked myself when I didn't know any of this stuff before. And it was through my own journey, some stuff with my children, that it just unmasked itself over a period of about 5 to 10 years where I could see it suddenly. And the question that you just asked me, I asked myself, where do we start?
Yeah.
And I've always learned that you start by mapping things out properly.
Yeah.
So when I realized how big this was, I collected together a group of international experts in each of these areas, in the autonomic medicine, in the gastrointestinal stuff, in the neuropsychiatric stuff, in the immune stuff. And together, we are developing a screening tool that has these various domains.
Yep.
One's called hyperimmune, one's called neuropsych, the other's called gastroflow, the other's called autonomic, the other is sensory.
Yeah.
And there's a new one joining the gang, which is hormonal, because this is very interesting.
Yeah. Yeah.
And each of these separate domains is going to have a screening questions or examinations, some of which are out there already. You mentioned the Baton score. It's not brilliant, but it's one aspect.
It's one scale, yeah.
And we're pulling together the various relevant scales and questions and brief tests and developing a tool. Now, the tool needs to be validated, but we're in the process of doing that. We're not there yet, but my view is that we need to understand who's in the group and what patterning have they got. Because when you know that there's a heavy mast cell burden, you're going to go in one direction. When you know that this individual's got like dysautonomia and is majorly affecting their life, then you're going to go in that direction. If it's more of a musculoskeletal connective tissue, then you'll go in that direction. Now, depending on what the problem is, there are stepped approach to interventions, ranging from what we term conservative measures. So just to give you an example, if someone's got lots of features suggestive of dysautonomia, they get dizzy and lightheaded on standing, 3 interventions that are tried and tested are increase fluid intake, increase salt safely and blood pressure allowing, and compression garments that, you know, depending on the severity of the dysautonomia determines how high up your body the tight clothes go. I actually think that although the evidence suggests that like socks that are tight, like flight socks, don't do the job for people with POTS. They need full compression leggings. I think with people with mild dysautonomia, i.e. presenting with anxiety to GPs, socks that are tight, that go up to here.
I think the compression
are
socks,
brilliant anxiety treatment.
Yeah, themselves though are probably poorly fitting a lot of the time. With, but that's another sort of separate.
So what I'm saying is that even if you're not an expert in that area, you would say, okay, there's enough here for me to say you need to see an autonomic specialist. I'm going to refer you to the autonomic specialist, and I'm going to, in the meantime, suggest that you increase your fluid intake, that we check your blood pressure, and if it's can tolerate it, that you increase your salt in your diet sensibly and carefully, and that we get you on compression. And I do this a lot, and I see a lot of improvement just with simple things. If we think your mast cells are reacting, then we need to stop and do an evaluation as to what is causing the because there's always something that's driving it.
Yeah.
Rarely is it like a genetic problem at root.
Yep.
It's normally an environmental thing. So when you get your symptoms, what have you just eaten, or what have you eaten in the last 24 hours? What did you breathe in? Is there mold in the room?
Yep.
Have you put new shampoo, conditioner? Have you changed the products cleaning products you're using in your home? Do you have an allergy that you don't know about? I will be doing a deep dive and detective work to find out what is, and I'll ask the patient to keep a record of when I get this symptom, I was doing this.
Yep.
And they'll keep a little notebook, and they'll start to put together. Until this point, it's amazing. People don't associate their environmental stuff with their symptoms. But I spend time doing that, identifying foods that are particularly problematic. And there are many foods that either contain high levels of histamine or they release histamine liberators. And there's a collection of vegetables, a collection of fruits, and pretty much all meat and fish, from the moment it was killed through to when it's eaten, there's a steady increase in its histamine content. So leftovers are a problem. And certainly any fermented foods.
Yes.
That's what you're doing, isn't it? You're fermenting it, and you get high histamine. It's sort of the tingle when you have sauerkraut or something.
Yes.
So you would reduce temporarily those triggering foods. You have to be careful that you don't limit your diet too much and become deficient in things. And start to notice patterns and connections. Allow the system to quieten down by reducing inflammation. Try and find the source and deal with it. If you're dealing with hypermobility that you don't know about, then you need to see someone to get it assessed and diagnosed, and you need to think about joint care, which is so relevant for your lot. And you can see if it's a sensory issue. By the way, those socks not only squeeze blood up the body. That compression is literally...
They give feedback.
Their proprioceptive feedback is unbelievable. And I think that's very important, actually. That's like the weighted blanket thing and the tight clothes thing. Some people can't bear it. Even, I think, when you scrub the body with a scrub or one of those loofah things and you slightly aggravate the skin, it's increasing proprioceptive feedback.
Yeah.
And I think that's when people are body brushing and stuff, I think we're not just moving lymphatic fluid around the body, but you're actually increasing proprioceptive feedback, making the system feel safe.
True.
So depending on where the problem is, you bring in stepped interventions, trying not to bring in heavy medications before you've tried simple things.
Okay.
That was a long answer to
that was a very in-depth answer, which is brilliant. Thank you. James, unfortunately, we've got to wrap up there because I could keep chatting and it looks like you could as well.
But some interesting in this stuff. It's great.
Thank you very, very much for your time. Utterly fascinating, and I hope it was insightful for our listeners because it certainly was for me.
Thanks very much.
Thanks
for inviting me.